This is a topic that I sort of see every day, and it's actually, you're going to recognize as we go through some of this today that some of these themes have already been expressed in the presentations this morning. But we talk about variation, and what the goal today is to talk about what exactly is variation, how does it impact cost, quality, and safety, and I'd like to show you a number of examples of how I think it impacts those important dimensions of healthcare. And if we come to the conclusion that reducing and minimizing variation is important, talk about how we do that, and maybe also share some obstacles to reducing variation. So I'll go back to a personal example. My wife and I are both 61, so 10 years ago, my wife went to see a physician, orthopedic surgeon, with what she and I both thought were sciatica. She plays tennis all the time. She's never had any arthritis, never any joint problems. And she calls me up at work. She's very upset because the orthopedic surgeon has just told her that she's going to need a hip replacement. Her left hip socket is totally worn away, and to even use a crutch as she leaves the office. And of course, she's just crushed because we had no suspicion, and we looked back, and she had fallen years before going up some steps and had a traumatic arthritis. So, move forward. We need a hip replacement. No real urgency to it. It's not an emergency procedure. So, some of the questions that I think we ask, and I think many people ask, is when should I have the hip replacement done? What implant material is best for me? And after I go through all this, what will I be able to do? Well, this was a time when I was transitioning from Alabama to Mississippi, so I actually had about 4 months when I had insurance coverage by 2 organizations, which represented an equivalent investment of $48,000, just so you all know what family premiums cost. So we had no lack of resources, no lack of physicians, so I contacted a doctor in Tupelo, Mississippi, and 2 in Birmingham, and I got completely different answers to all 3 of these questions from those very fine doctors who honestly were telling me what they thought she should do. At the end of the day, we chose the doctor who actually spent an hour and a half explaining to us, and then I called around to all the hospitals in Birmingham and talked to the CRNAs, and I asked the CRNAs, who is the most fastidious orthopedic surgeon in the operating rooms? And I said, oh my gosh. So it was actually, we ended up making a good choice, but this is a procedure that's done 900,000 times a year. It's very costly. Would we not agree that there should be some sort of standard approaches to this? So sort of a personal experience. So a paper came out from the American Hospital Association in 2011 with a degree of urgency about the need to reduce variation, because in hospitals you see this all the time. And this is just a brief schematic. But the point is that some variation is good, and some variation is to be expected. But when you can't explain why we do the same thing 2 different ways, it begs questions. If it doesn't have anything to do with quality and safety, it may certainly have something to do with cost, and we're all interested in reducing cost. I remember when I was with Ascension Health, we had a large Ascension Health multi-site study going underway as in terms of how you treat a pressure ulcer. We found that one hospital spent $10 per episode treating a pressure ulcer. Another hospital spent $190. There's 400,000 Medicare pressure ulcer patients each year. That grows into large numbers. So variation exists at all levels of the system across all performance dimensions. What doesn't make a difference is private pay or Medicare. We talk about hospitals, but it's in all settings. And we always talk about hospitals because they absorb such a large piece of the healthcare dollar. We do know that all of us respond to financial incentives to reduce variation. That's what a lot of the programs we're seeing now. And we also know pretty well that what we spend does not necessarily correlate with the quality of the product that we get. And in fact, if you look back at really some well-run programs, you'll find that the best providers in the long run are often the less expensive. So here's the official statement of the American Hospital Association. Some variations expected, but if we take an opportunity to look at each other and see how we actually practice, our colleagues, we will not be able to explain why some of us practice different. So let's start with sort of that macroscopic view. This is the traditional Dartmouth Atlas chart. This is price-adjusted Medicare. Well, how much do we spend per Medicare beneficiary in a given area? And these are metropolitan service areas, and you can see very evidently across there that Texas in the south and up Ohio Valley, it seems like we spend a whole lot more money per Medicare beneficiary than we may do in the Northwest. And of course, there's nothing inherently wrong with that at this point. We'll talk about this a little more. But if you are an owner or president or CEO of a large company that funds your own health care, you've been exposed to a lot of papers from Thomson Reuters and a lot of other large consulting firms that tell you that this variation represents one dimension of the tremendous waste that takes place in U.S. healthcare each year. So if you're a large employer, when I was with Alabama Power, this paper came out that said 30% of what we spend is waste in this country. So their employers are convinced there's huge opportunities. And so they're convinced it's not the R word we should be worried about rationing, it's the W word. So if we look a little more at variation in cost, and this touches upon MACRA and MIPS when they talk about resource utilization. This is some of the data that will go into that. You see this in a little more detail. And you say, well, all of us can offer answers as to why this variation exists. And some of them are very obvious. They got sicker patients. Maybe you have a supply of orthopedic surgeons in one area and you have no orthopedic surgeons in another. Some of that stuff is supply sensitive. We talked about a little bit earlier, we mentioned malpractice. Maybe malpractice environments promote higher utilization of services. You know, how you are trained, that middle one right there in the middle, how you are trained probably influences how you will practice for the next 30 years. So a lot of different things go into this. So if we were to say, okay, let's figure out how much the health status, the Medicare special payments, the supply of providers, the socioeconomic status, the lifestyle, let's take into account smoking, obesity, and all these things. And let's see how many of those things impact this variation in spending. We do that, and we're still left with 56% of those costs being unexplainable in terms of the patient population or the provider training or the environment. So that, to many, represents the huge opportunity for all of us. So if we have inappropriate variation, that's simply a cost issue. Well, if we underutilize services, we know that we're probably going to have a worse outcome and higher cost. If we overutilize services that aren't needed, not only are we wasting money, but we expose people and individuals to false positives and things that can happen from having a wrong diagnosis. And we all know that some statistics will suggest that cancer diagnoses, for example, are wrong at least 10% of the time. So whether we underuse or overuse, the result's the same, higher cost and worse outcomes. This is an interesting article back from 2003 in New England Journal. In America, there's no guarantee that any individual will receive high-quality care for any health problem. Wow, that's a pretty big statement. What were they looking at? Well, you can't read it right here, but what they did is they took 12,000 patients in the New England area, 4 metropolitan areas, and they went through their medical records over a period of time, and they looked at all these conditions, everything from cataracts to alcohol dependence to asthma to colorectal cancer, osteoarthritis, and that's how they drew this conclusion that when they looked at the care, it varied so much. Not only did it vary, is that some of it seemed to be quite inappropriate or incomplete. Is this still true? That was 2003. That's 13 years later. Is this still the case? Well, going back to that paper that was shared with a lot of large national employers from Thomson Reuters, they say this is where the waste lives. So we got administrative waste. I can certainly see that. Provider inefficiency. My gosh, the way we have so many challenges in communicating with one another and the duplication and the gaps, we all see that every day. We see a lot of unwarranted use. Someone was talking about, I think our gentleman here was talking about when somebody, all of a sudden when the ER management or ER employment changed, the number of studies in that setting went up. A lot of this stuff. So $700 billion, 1/3 of what we spend. I ran across this quote I thought this was very interesting. Healthcare is a $2.7 trillion tank rumbling down the road. Hundreds of people have their hands on the wheel, pulling in different directions, shouting in different languages. The windshields are smudged with Vaseline. The tank is providing decent protection for a lot of people, but it's smashing into trees and houses. You say, well, who in the world has the chutzpah to make a statement like that? Well, who is Dr. David Eddy? Chief of Bioengineering, U.S. Army, Professor of Healthcare Policy, Duke, Cardiovascular Surgeon, Duke, Chief Scientist for the Blue Cross Blue Shield National Association, Director of the World Health Organization Center for Research. He's certainly been exposed to a lot of data. He's seen a lot of stuff. So there may be at least something to this. So let's go back to the spine and the joint, because these are procedures, like I said, that are done so often. And this is just in one state. This is Washington. And they're talking about hospital charges and how they vary for a routine spine. None of this is emergency. This is all routine spine surgery. And you can see that the charges vary from $61,000 at one hospital to $93,000 at the top. And you say, well, that's largely irrelevant, because you look at what's paid by Medicare, it doesn't differ that much. Well, that's true. It doesn't differ for Medicare, but it certainly differs for private payers. And it really differs for those people who don't have Medicare or private insurance. But more importantly is, why would it differ so much anyway? Are we really doing hip and spine surgery in so many different ways? So if we go back and we look at another example, this is the California retirement system, huge population of patients. And so they collect huge amounts of data on their beneficiaries. And this is just in California. And they say this is for a knee replacement. And they look at each one of those little dots is a hospital in California. And this, of course, is the charge for the procedure. And you can see it varies from $12,000 to $74,000. Well, in this study, what they found was it didn't make any difference whether you were paying 12 or 74. None of that correlated with the quality of the product. So what CalPERS did is they say, listen, we need you to get your knee replacement, and we need for you to get it done right. But we found 46 hospitals that will do it right and have great outcomes and charge about $30,000. So we are going to give you $30,000. It's called reference pricing. And we are going to give you the list of those hospitals. You are free to go to the one that charges 40 or 50. It's just 10 or 20 more out of your pocket. And you're going to start to see more and more of this type of movement when it comes to how we pay for healthcare services. But you can see all this depends on the aggregation of large amounts of reliable data, which remains a big challenge for us. So you say, well, we're talking about difference between states. What about differences in a city? And you see Atlanta, Georgia, someplace near and dear. This is private insurance cost. Again, we're seeing, this is a joint replacement in Atlanta from $5,000 to $30,000. And I dare say most patients have no idea that those differences even exist when they go from one hospital to another. So if we break it down into, say, this is a Blue Cross Blue Shield national study of the variations in knee and hip replacement, the only thing to glean from this, if you're from Birmingham, Alabama, you probably knew this already, but you are the lowest cost market in the United States to have a knee replacement. The doctors down in my way complain about this all the time, is that the hospital gets an average of $11,000 for a knee replacement. And if you go to Boston, the hospital gets $72,000 for a knee replacement. The dots on each of the maps represent, the larger the dot, the larger local variation in cost. And again, so I'm just sharing stuff. It's like, man, surely this provokes a question. So when I was in Mississippi, Mississippi was, at that time, was kind of unique because Blue Cross Blue Shield, the National Association, was coming into Mississippi, or the local Mississippi Blue Cross was adopting the national policy called the Blue Distinction Center for knee and hip replacement and for joints, for spine, for cardiac, for bariatric, a lot of what hospitals do. And they had notified Blue Cross subscribers in Mississippi that only going to be 5 hospitals in Mississippi that would do knee replacements under the Blue Distinction program. And patients were free to go to another hospital, but there would be a 30% copay on a $30,000 procedure. So we said, well, why is Blue Cross doing this in Mississippi? Tom Fenter, a friend of mine who's medical director of Blue Cross, he brought me this data. He said, well, Mark, these are the Mississippi hospitals for elective joint replacement. This is just sort of some of the simple data. Okay, on that bottom right, would you like to have your knee replaced at a hospital that did one joint replacement last year? Or do you know you're going to a hospital in the upper right that the average length of stay after having this done is 7 days versus 2 at your higher performing hospitals? And again, how many people know this data? And of course, I don't want to make it too simple, but those are not small differences. They're huge differences. Now, this is an article that came out last fall, in late 2015. It says, well, I guess if we're spending more money in Medicare in this area, we're probably spending more money in private insurance as well. Well, the article actually showed the opposite. So let's take a market where, like many of your markets, where hospitals are all coming together, consolidating, and they actually become very efficient with Medicare. It's a DRG model. They come together, they figure out how to reduce their cost. And if, like North Mississippi Medical Center in Tupelo, the average margin on a Medicare case is almost $4,000. They make money off of Medicare cases. But when this consolidation comes together in a market, the hospitals now have more power with the private payers. And they tend to raise the prices on the private insurance market while they still can make money on the Medicare market. So it's actually often the opposite. So this is an article that came out in 2009, and it was actually talked a lot during the healthcare reform debate. So Dr. Gawande, many of you will recognize Dr. Gawande. He's that very prolific writer out of Boston who is he's just phenomenal. I mean, the guy, not only is he a gifted writer, he knows so much about healthcare, but he was interested in this variation issue. So he went to that Dartmouth Atlas that I showed you on the third slide, and he said, okay, let's look at a state where we had the same malpractice environment, we had the same training environment, geographically we're close, the city has the same demographics. So he found 2 cities, El Paso and McAllen, Texas. And he went there, he traveled there, and he got all the data. And he said, just took some common studies, some of them very expensive, pacemakers, some of them less expensive, but you got abdominal ultrasound, stress tests, nerve conduction studies, pacemakers, nursing home visits, urine flow studies. And the scale on the right, for example, that 6 represents 600% more. So if I came in with an arrhythmia in El Paso, Texas, I might get a pacemaker. But if I came in with that same person, same arrhythmia, came into McAllen, Texas, I had a 300% more chance of getting a pacemaker placed there than if I had stayed in El Paso.
So this is utilization, not cost.
That's correct. Okay, but it was at first identified by the cost map. Okay, so I mean, as a consumer of healthcare, does that concern you or raise any questions? Or, I mean, number one, am I getting a pacemaker unnecessarily? And am I going to be anticoagulated for the rest of my life unnecessarily? What's the difference? What do y'all think the difference is? Not malpractice, not training, not geography.
What's the socioeconomic situation between El Paso?
The demographics were matched up. Yeah.
You don't have outcomes data, do you? Mortality rates or anything?
Oh, I'm so glad you asked.
Okay.
I mean, because it may have been worth it. We may have much better outcomes, right? I mean, then it would be justified. In fact, we might want to spend more if we had better outcomes. So, but what do you think the difference was?
I'm guessing they're going to be the same.
They're the same outcomes, all the same outcomes.
All these things you are telling, is there are 4 arms controlling healthcare: physicians, hospitals, pharmaceutical industry, and the insurance company. There is no control over anything, anywhere, any place in the country.
The 5th is attorneys. Does McAllen have a lot more attorneys?
Same malpractice environment. Okay, I'll move forward, but the bottom line was in McAllen, Texas, almost all facilities are owned by doctors. They own the hospitals in McAllen, they own the surgery centers, they own the home health companies. And again, that's not an indictment of physician ownership, but it is a reality in McAllen, Texas. So if where you live matters in terms of cost, does it matter in terms of access? So these are two, again, these are high level, but that bottom right is Medicare beneficiaries who received at least one drug that should be avoided in the elderly. The other one is risk-adjusted 30-day mortality among Medicare beneficiaries hospitalized for MI, heart failure, pneumonia. And again, so we're talking about cost on one dimension, and now we're talking about quality and access. Again, those are not subtle differences. Those are huge differences. How do we understand and explain that? So let's go back to spine surgery again, because again, it's such a big deal. And I live down in the South, and Southern Medical Association's down here in the South, and you say, okay, or let's say I'm a company CEO and I'm fixing to move my company, and healthcare costs are a real big deal for me. So I say, okay, let's see. Rate of inpatient lumbar decompression and fusion. Man alive, I live in Birmingham. I'm much likely to have it versus living in Atlanta. But you can see these differences. They're like, again, they prompt questions, and some of them are pretty big questions. So going back to our purpose today is to determine how much variation is acceptable. So now we're going to get into sort of physician thinking and perspectives. You all know if you live in a hospital now, there's tremendous movements to reduce the rate of blood transfusion. We now view blood as beneficial in many circumstances, but certainly very harmful for other reasons. It's like a transplant. It affects immunosuppression, it has infectious disease risk. And when, for example, Blue Cross came to us in Mississippi with the Blue Distinction Program, one of their metrics was an expectation that no knee replacement would ever get a transfusion. Their expectation was 0 transfusion rate. So we say, okay, well, how many people transfuse in hip and knee cases? This is from the advisory board, June 2015. On the left is the number of institutions. And you can see, so on the far right, there are a number of institutions, not many, but they transfuse every single case. You look to the far left and you can say, well, about 10% of the patients, about 10% of most of the organizations, the three on the left, 3 bars on the left, most of the organizations transfuse less than a third of the time. Wow, how do you explain that? Well, I'll give you one example. I'll go back to Tupelo. So we had 14 orthopedic surgeons in Tupelo, 4 different groups, some older, some younger, some right out of training, some been training for 30 years. And we said, man, this blood transfusion thing from Blue Cross is going to be a challenge for us because our transfusion rate's going to be high, and if we can't keep it down, we'll lose the Blue Distinction opportunity. Well, it turned out that when I got 14 doctors in the room, 6 of them were in one group, and we started talking about this, you quickly discover that the 6, even though they've been in the same group, have never talked to one another about their transfusion practices. We still have this individual practice of medicine, even in group practices. And it's usually a very satisfying, pretty thoughtful, fun discussion when someone says, oh, you mean you use tranexamic acid now? And the young guy says, oh yeah, we always used it all the time in training. And so what we found out is that this one little aspect of treatment, the use of an antifibrinolytic agent, tranexamic acid, in elective orthopedic surgery, almost totally eliminates the need for transfusion. Totally. So I had these older surgeons who are great surgeons, want to practice great medicine, but how come they don't know about that? Their partner knows about it. The person who really knows the differences the best is usually the OR nurse. She can tell you the difference between all the surgeons. So this is another thing about knee replacement, but let's go to transfusion practices around the world. And again, huge differences. You can see just looking at the difference in the bars. Again, this is elective surgery. So you've all heard that in our healthcare industry with physicians, it takes 17 years to put evidence-based medicine into practice. It takes 17 years to get a doctor to change their habit. Is that true? So our own professions, our own specialties have started saying, you know, what do doctors need? These doctors want to practice good medicine. What do we need? Do we need another government regulation? Do we need another mandate? Do we need something legislated from the state? Well, you're probably familiar with the Choosing Wisely campaigns when our own societies have come together and tried to address some of these big issues. So even on blood utilization and management, we have 8 or 10 of the societies have already spoken. And now they began to offer clinical guidelines, which in the future, going back to the concerns about defensive medicine or malpractice, now offer you evidence about what you can use as you promote the right practice of medicine and begin to move away from ordering studies because of the fear of being in a courtroom one day. If you all haven't seen these things, I'd advise you to look at them. Every single one of your specialties is represented and has a very robust set of protocols. And for example, in my society, American Society of Anesthesiologists, it says an elective person undergoing elective surgery and the blood loss is over, don't transfuse for a hemoglobin over 6.5. When I grew up, it was 10. Huge difference. So why so much variation? Well, we now have 300,000 over-the-counter products. We now have very complicated care settings. We've got 10,000 biologicals. We got 22,000 random controlled trials each year, 16,000 new articles per week. To maintain current knowledge, a general internist would need to read 20 articles per day each day of the year. You could be trying your best, working your hardest to stay up to date, you still can't do it. And even if we read and learn and we're able to do that, less than 20% of medical practice has a true basis in clinical research. You all, if you looked at your Washington Manual of Medical Therapeutics or Surgical Therapeutics that you used 30 years ago, you'd probably, and tried to redline it now, the whole thing would probably be redlined because it's all changed. But when did it change? And lastly, over-reliance on subjective judgments. For those of you who don't know me, you probably formed an impression of me within the first 2 or 3 minutes of my talk, and that was your impulse thinking. The way we think as physicians really influences how we identify and treat patients. So that gets into the art of medicine. If we talk about reducing variation in healthcare and maybe using protocols, are we diminishing the notion of the art and craft and your skills as a physician? So we know that only 20% of what we really do is based on real studies. And we know that we heard a gentleman, I think Dr. Urban, say the way you were trained probably influenced this, no matter how long ago it was. So how we were trained, where we practice, and how our experiences have been with patients. If the last patient we saw had this type of infection, our mind is already primed to think that the next patient may have that type of infection subconsciously. So how have we been trained? Well, some people would say that doctors and administrators are white coat leaders. We were expected to know everything. We're all supposed to be in charge. We demonstrate independence and autocratic tendencies. We do have a sense of responsibility and that the buck stops here with us. We get impatient when other people don't seem to take things as urgent as we do. We do have a tendency to point to problems, to other issues, and we have a history or reputation of wanting to control others. The captain of the ship, you've all seen it. Do we need a transformation in how we interact with others? Do we need to be more humble? Do we need to be more curious? Do we need to really embrace improvement, even though it may be hard? Do we need to teach better, learn better, and communicate more effectively? Now, in our system in Birmingham, and when I was at Ascension Health, I was chairman of a task force at Ascension Health. What do you do? And it was called the Task Force on Unexpected Outcomes. what do you do when things go bad? How do you communicate with the family and the patient, how the staff? And in my various roles over the year, I've learned that the CEO gets to keep all the letters that come to the organization thanking the organization. Those are up on his wall. And all the ones that are complaining all go to Dr. Williams' office. But it has provided, between peer review and that, a window into, man, there are a lot of opportunities here when it comes to communication and understanding.
Mark, go back to that slide.
Mhm.
So one of the things we recently changed with SMA is vision statement and
Mhm.
so forth. And part of it is it's physician-led, but we don't want to be in the green box, we want to be in that yellow box.
That's right. That's right.
It dawned on me that what you're talking about is very with SMA.
Thank you. Thanks, Clem. That's right. And again, I am not, this is not a criticism of either type of model, but if you look at how we were all chosen for medical school and how we were all raised, we were chosen basically because we were alpha dogs. We beat out everybody else on the grades. There was no measure of teamwork and real empathy for us to get into medical school. And we all know that medical school education is evolving even now to embrace some of this. Okay, well, let's say we've identified that doctor. We now have good data, and we've identified that doctor, and you say, man, you are an outlier. You got so much variation here. So this is an example of what I might have done in Mississippi. We had a very great tool across our system called Premier. It allowed us to capture clinical practice guidelines. And this is just an example of sort of fictional, but it basically says across that bottom graph there, and this just for example is a vascular procedure, along the bottom is cost per case. And so each one of those circles that you're seeing across there is not only reflecting cost per case, but the relative size of the circle represents how many cases you did. So there's this Dr. J, the average cost for this case for all of our doctors is $20,000, but the average cost for him is $60,000. Doing the same procedure, same place, 3 times as much. We need to get rid of him, don't we? Educate him. Yeah, educate him. And before we jump to a conclusion, and hospital folks are notorious for this, for drawing conclusions prematurely, what if he's taking care of the sickest patients in the frickin' hospital and that $60,000 is justifiable? Let's don't jump to conclusion and say, education is critically important for all these physicians, but let's be careful how we draw conclusions. And the very first thing that we have to assure before we ever present information to a physician is it needs to be accurate. Because if it's not, the rest of the discussion is largely fruitless. So let's go back to a physician's ability variation in how are you going to do if you had this procedure. Ask 50 cardiovascular surgeons to estimate the probabilities of risk associated with xenografts versus mechanical heart valves, and you'll get answers to the same question ranging from 0% to 50%. That's from a book that came out a few years ago, our excerpt from Demand Better, Our Broken Healthcare System. And again, we encountered the same thing with my wife's joint replacement. So these are some of the challenges. We've talked about most of these already. Medicine still is an art. There's still a lot of gray area. How we share best practices, despite the ubiquity of electronic health records, it's still very, very hard to share best practices. We've already recognized the legal and the regulatory barriers. We know that when it comes to variation in diagnostic rates, we know that our diagnostic failure rate in the ER, internal medicine, family practice settings is as high as 10 to 15%. And now I'd like to introduce what you all know a little bit about already is cognitive errors. This is on the physician side. So these are some of the biases that all of us as normal human beings demonstrate in our everyday thinking. Anchoring, confirmation bias. Let's just take confirmation bias. Patient comes in, we have a diagnosis in our head right off the bat. we began to look for lab studies that confirm the diagnosis, and we may not be looking for other lab studies that are still needed in the differential. That's very natural and normal, and I see it in peer review all the time. A young lady comes in with bleeding. The ER doctor has already made the assumption that the home pregnancy tests are notoriously inaccurate. Well, he's behind in his knowledge, but he's already made a prejudgment before he's even considered what diagnostic studies he's going to pursue. He's not being malicious. He's working on what he thinks is right. But it's interesting if you all will ever have time to just read about how these things influence your thinking. There are a lot of books, fast thinking, slow thinking, different things. But you begin to recognize that I do these things all the time. Now, near and dear to my heart, I'm an anesthesiologist, critical care medicine, and I get this a lot. Let's say that there's a known safety rule in your hospital. Let's say it's, I'm going to use an operating room example, but let's say it's placing a central line. And we know that 5 or 6 steps virtually assure that you will never get a central line associated bloodstream infection. Chlorhexidine, letting it dry, draping, masks, gowns. I mean, it's not complicated. Now, when a doctor or nurse fails to do that, and the patient doesn't get an infection, what happens to the doctor or nurse? Nothing, right? Which is different from a lot of parts of our society that if we run a stop sign at a 4-way stop, and even if there's no one else at the other 3 stop signs, you're probably going to get a ticket, right? And most people would say you should. So variation in the application of safety practices is huge around our organizations. So here you have 2 protocols, both designed to make sure you don't get the wrong surgery at the wrong site at your hospital. The Universal Protocol in 2004 wasn't brought to us by the Joint Commission. It was brought to us by the American Academy of Orthopedic Surgeons after they got tired of operating on the wrong finger all the time. But today, we still have so much variability in the adoption and application of safety practices. So doctors will say those are checklists. I don't believe in checklists. Well, okay, so here's a doctor who said, man, at Johns Hopkins, the world's finest hospital, 11% of our patients in the ICU are getting CLABSIs. And a CLABSI carries a 25% plus mortality rate. Adds $45,000 to a hospital stay. So he started saying, let's look at some data, and let's wash our hands, chlorhexidine, drape, mask, sterile dressing, and lo and behold, within 6 months, at the ICUs at Hopkins, they went from 11% infection rate to 0, using a simple checklist.
What were they not doing?
They weren't, well, most of the time they're not washing their hands. And I'll give you an example from my daughter at University of South Alabama. She was a critical care nurse. She's putting in a central line in the middle of the night in the ICU with the chief of trauma surgery, and administration has told Jessica, fill out the checklist, Jessica, make sure your doctor does all these things. And we frequently put nurses in untenable positions when it says, tell the doctor to do this. She very gently asked the chief of trauma surgery, Dr. So-and-so, am I going to be able to check the box that says you're wearing a mask? You know, there's no mask. He very kindly says, you're trying my patience, lay off. How much of that still exists in our profession? So where did Dr. Pronovost get this idea for a checklist? Which again, Dr. Gawande wrote about the phenomenal success of this Dr. Peter Pronovost checklist in the Annals of Medicine. Well, Peter is a friend of mine, and I said, Peter, where did you get the idea for checklist? He said, well, Mark, you remember this thing. Peter and I are both aviation buffs. And so here in the pre-World War II period, Wright Airfield, you have the competition for the next generation bomber, and Boeing, Mr. Boeing, has literally bet the company on this one plane. And it is an awesome plane. It's much better than the competitor planes that are coming from Martin and Douglas on the day that all 3 are being flown here at Wright Airfield. I mean, Boeing, if they don't get this business, is going out of business. So what happens? The only thing about this plane, it's somewhat complicated, but what happens that day, it's kind of like in front of the press and in front of all the, at that time the Air Force was under the Army, all the U.S. Army Air Force folks, it crashes on takeoff. And they immediately say, can't have that plane. These were accomplished test pilots flying this plane. They couldn't even get it off the ground. And Boeing's going out of business. There's not going to be a 707, a 747, 737, 787 ever. So what did the pilots do? They said, no, wait a minute. No, this is a better plane. This is a better plane. But it is hard to fly. It requires the pilot to do a lot of things right at the time of takeoff and liftoff. So what can we do about that? So here is the first known checklist in aviation. The pilots went back and said, listen, if we can just say, what does the co-pilot do and the pilot do, and write it down so we don't have to be dependent on an individual's memory, that's what we'll do. And sure enough, that plane became the world-famous B-17 bomber. So that was where the idea of a checklist came from, where let's don't put too much pressure on the human mind to remember important things. This is something that's really bugging me right now at our organizations. In Tupelo, we had a gentleman who was actually in charge of our wellness center, Hank Boehner. And Hank was, the wellness center in Tupelo is the equivalent of a world-class YMCA. It's just a great facility. And Hank was the Mr. Fitness guy for the organization. He came in late with a urinary tract infection and ended up dying in the hospital of sepsis. And you say, well, how do people die of sepsis these days? I mean, especially young and healthy people. And in fact, how is it that we can explain that 1/3 of all hospital deaths are due to sepsis? And this Surviving Sepsis campaign is only one example of a protocol that's been in place for 10 years, put together by the American and European Societies of Critical Care Medicine. It's not hard. Measure lactate, obtain blood cultures, give antibiotics, administer 30 cc's per kilogram of fluid. It's not hard, and please try to do that within the first 3 hours. You don't even have to put in a central line anymore. So I find at one of our hospitals that this protocol over the last 1 year, and this will be reported by Medicare later this month, is that in the last 1 year, a 650-bed hospital has only embraced this protocol 11% of the time. And of course, the more you wait, maybe your mind is saying to you, let's wait for some more diagnostics so I can be sure that it's sepsis. For every hour you wait, the mortality rate goes up 8%. So I say, why is there so much variation in this? Why can't we accept a protocol? Why do people believe that some protocols are worthless and I'll never use them, and other people say I need them? Well, I'm going to sort of be wrapping up here, and I appreciate your time today. But at the end of the day, our ability to spread information, reduce variation, adopt best practices needs to lie with the medical profession. We talked about regulatory and Medicare and lawyers. This is a young lady, 5-year-old, named Gabby Galbo. And I don't know if any of you have heard of Gabby's Law. So Gabby's Law came about when Gabby's parents became concerned. I think it was a urinary tract infection, or it may have been a URI. But over a period of 5 days, they went to multiple healthcare settings. And in retrospect, on the very first visit, she had those signs of sepsis. But each time, the doctor or healthcare provider, not being malicious, not wanting anything bad to happen to Gabby, moved in a different direction or ignored the symptoms. And of course, she died a horrible death. And the parents were so distraught about how is it that such a common condition and such a well-known protocol are not brought together to save her life and the lives of 1/3 of our hospital patients. So what we don't want to go, so Illinois became the second state after New York to say that hospitals and other settings must screen for sepsis, must do these things. And again, we can point to that as, oh my gosh, more regulatory oversight. But perhaps the better perspective is, what did we as a medical profession not do that prompted this development? So will physicians lead, or will they leave it to others? I'll end with these 2 slides. And my dad recently underwent a complicated cardiac procedure. And you're saying to the doctor, what are my risks when I have this procedure done? And again, we heard in an earlier slide that a given doctor, well-meaning, same procedure will quote a whole range of risk because they're not maybe up to date. Well, there's 2 registries now that are out that I particularly encourage you all to use if you do procedures or you're having a procedure. One is the American College of Surgeons, NSQIP, and the other one is the Society of Thoracic Surgeons National Database. And for example, you could go right now, you want to have a hernia repair, you want to have elective gallbladder, you got diabetes, you're obese. Add the demographics. It takes 1 minute. You put that all into the free NSQIP tool, which is based on 500,000 patients. And here's everything from the risk of complications, the risk of pneumonia, the risk of cardiac complications, how long you're likely to stay in bed, in the hospital, how likely you're going to need rehab, predicted length of stay. We are moving into an era in which this information is available. So one last example, going back to Mississippi. When I first came to Mississippi, Tupelo was already famous for measuring cost variation. And over that time, just by looking at the protocols for the common procedures, these are just common DRGs that the hospital was losing money on, they eliminated $12 million in cost and improved care. From a selfish standpoint, that ability to eliminate waste has given that organization a tremendous advantage when it wants to grow, pursue, pay physicians, recruit specialties, build specialty facilities. So there's a lot of merit in all of this. So in Dr. Deming, your opportunity here is not only to have the knowledge and the personality, but the persuasive power to talk to your colleagues about the opportunities here. He is the gentleman who started the movement to reducing variation. He was pretty much singularly responsible for Japan recovering from World War II and beginning to manufacture quality products. So thank you very much. Appreciate your time today and glad to field any questions.